Hear me?
Yes, I can.
Uh, have you taken I've given you the mouse control also, and have you got it? Can you move the mouse as a try?
Um, I don't think so.
No.
I can try. Yeah, I can.
Okay. So there will be cases. First of all, I'll do some a few slides teaching, and then I will give you in a PowerPoint mode. I will give you a case to scroll through. So let's see if it works. Right. Actually, today, tomorrow, and day after, what I have done is I have selected rapid fire cases, and the mandate is MRI. So they are from MSK Word cases which have come in the exam in the past, and there will be a bit of repetition, and this will give you a consolidated type of overview of what kind of MR cases from the MSK world can come. And second bit is that day after tomorrow when we do spine, and we'll try to do the same for the spine also. In MRI, MSK, I think the most important cases as far as knee is concerned is polytrauma, which has come in as long case, which has come in the VIVA. Polytrauma case will always have multiple findings, as I told you in the beginning. Meniscal tear, collateral ligamental tears, ACL rupture, and patellofemoral dislocation, relocation, all of these things which Dr. Butt today taught us. So that kind of a case is very, because in knee, that is, I believe, the most important one. Similarly, in shoulder, supraspinatus tears and Hill-Sachs lesion, recurrent anterior dislocation, which we will cover tomorrow. But other than that, most popular cases in the exam are subtle cases, so they will show you a plain film. On that plain film, there will be a subtle finding. At times, it will be an obvious finding. Once you pick it up, then there will be a differential diagnosis. And then, how will you characterize? And your answer will be, I will do an MR. And then they will show you the MR, which will make the difference. Please remember, the terminology of aggressive lesion, because infection versus tumor, particularly infection versus Ewing's, for example, in a young patient, is a very popular case. And these plain films will always be very subtle. So please remember that MR at times is diagnostic to differentiate between the two. Use the word aggressive lesion. It can be infection. It can be a tumor, let's say Ewing's. And point to remember is that both of them can present with what we call, fever and raised ESR and all of those things. In the real world, there will be always cases which cannot be differentiated on MR, and you end up doing biopsy. But the black and white cases where there is a discriminator, for example, if there is an intraosseous abscess, tunneling, soft tissue abscess, then it's a black and white osteomyelitis. So that kind of cases are quite popular in the exam. Just a recap quickly that these are all VIVA questions, and that for local staging you will do an MR if there is a tumor, and one VIVA question is that you will do at least one lesion in which the whole bone is covered. For example, if there is a tumor here in the distal end of femur, you have to do one sequence covering whole of the length of the femur till the hip joint. And the rationale is to pick up any skip lesions. So, in Stanmore, which is Royal National Orthopaedic Hospital, please remember in UK, we have got specialist bone tumor centers. And in London and in surrounding areas also around London, all cases are sent to RNOH. They do a single T1 weighted sequence covering that bone. For rest of the staging, you can do a CT chest, but if there is a liposarcoma, you can do also CT chest, abdomen and pelvis. Whatever you say, it doesn't make a difference. Please remember things like osteosarcoma, which cause pneumothorax. You know that. That has come in the exam. Nuclear scan you will do, but another thing is, just 1 second, let me disable the annotations. Right, so nuclear scan. In some centers, whole body MR, which include a T1 star, is now being used. And if there is Ewing sarcoma, there is a role of PET scanning. And in the VIVA, you will always say that I will refer the case to a bone tumor center. Never say that I will do the biopsy myself. Okay, from the perspective of the exam, marrow is, for marrow imaging, the key sequences are T1 and STIR. Remember that. T1 and STIR. On T1, the fat will be, because of the fat content of the marrow, it will be high signal. And if you work out a PD weighted sequence, it is very difficult to differentiate between the marrow. But please remember that the soft tissue structures like ligaments, tendons, etc., they are better seen on PD weighted sequence. So that's how you can discriminate between the two. Usually, examiners will not show you a PD weighted sequence. They can show you a PD fat saturated sequence, which is a most widely used sequence in UK because this sequence allows you to see everything like bone bruising and ligament, menisci, tendons, etc., just utilizing a single sequence. STIR sequence, which is very good to pick up bone marrow edema, better than PD weighted sequence, but you don't do it as a routine. On the other hand, if you are worried about infection or trauma, you would like to include it. Okay, candidate 1, rapid fire. What is your diagnosis?
Bilateral avascular necrosis of the femoral head.
Right. What is double line sign? Can you describe it on this case?
So double line sign is a sign that you see with AVN, and it's two-part process where you get granulation tissue and dead bone.
So on which sequence, this is a VIVA question, on which sequence you see the double line sign, and can you point it out to me?
Here on the T1 weighted sequence.
Can you move the mouse? I cannot see the mouse. Yeah. So can you go back, please? Yeah. So the point is that it is seen on T2 weighted sequence, and double line sign is on T2 weighted sequence, and these two lines, one of the interface between normal and abnormal bone, and second is granulation tissue. So this is an exam case. This patient has presented with pain. What is your diagnosis? And what will you be worried about? What will you do?
So my diagnosis is an osteochondroma. I'll be worried about a malignant transformation. I would correlate to see if the patient has previous imaging to see if this has grown, and I would also correlate the patient has pain, so I'd recommend an MR to measure the cartilage cap.
This is the one sequence of MR.
So on this axial sequence, I can see the same corresponding osteochondroma. So I would measure the cartilage cap, and if it's more than 15 millimeters, then that's an increased risk of sarcomatous transformation.
And this one actually is less than 1 centimeter. It is less than 10 millimeter.
So if it's less than 10 millimeters, I wouldn't be worried about malignant transformation.
Right. So please remember, osteochondromas have come in the exam, and osteochondromatosis and various syndromes, and there is a rate of malignant transformation. Pain is taken as a sign of malignant transformation. So pain is taken, but counter argument is that many a times because of mechanical effect, patient will feel this pain. So you are absolutely right, comparison with previous film, but at times it might not be very helpful. You do an MR. On MR, you measure the cartilage cap. Less than 1, there is a black and white world, and there is a gray world. The black and white world, there is a bit of discrepancy in literature, but having said that, everybody agrees that less than 1 centimeter is benign. And more than 2, and some people think more than 2.5 is taken malignant. In between is the gray world. From your perspective of the exam, when you are in the gray world, if it is between 1 and 2, even then you will say that this is it. I will take a second opinion. I'll refer the case to a bone tumor center. Another osteochondroma, what is again increasing pain, what will you do?
So again, I'll compare to any previous imaging and would recommend an MR to further characterize.
Here is the MR.
So on the MR, on the axial T1 weighted imaging, I can see the pedunculated structure. It has a very large cartilage cap associated with it. I can't measure it, but just looking at it, it does look larger than 1.5 to 2 centimeters. So I would be concerned about malignant transformation to chondrosarcoma in this patient, and would recommend referral to a specialist orthopedic unit.
Okay, fine. If you see, this is the bony part, and then this is the cartilage cap. You don't have to measure it. It is definitely more than 2.5. Cartilage on a T2 weighted sequence or a PD weighted sequence, it appears as high signal. And if there is some calcification, etc., that will be, which is the chondroid matrix, that will be low signal. So this is potentially malignant. Okay, let me now try to show you a case in a sort of a scrolling format. Let's see if it works. So candidate 1, can you see case 1 written in front of your eyes?
Yes, I can.
So I am going to give you the mouse control again, and let's see if now this case is a 19-year-old right lower limb swelling and tenderness. So there was a calf swelling there.
Okay, so got a frontal radiograph of the right tibia and fibula. I having a look at the fibula, the mid shaft, there's an eccentric area where there is poor definition with some cortical irregularity. And I can also see an impression of a soft tissue component in the tibia and fibula surrounding both the tibia and fibula on both sides. And I can also see foci of calcification, which would be unusual for a patient of this age. Given putting all these together, I'm concerned about a soft tissue process causing an extrinsic compression on the bones. And
right. So this is the lateral?
Yeah, and the lateral confirms this, where you can see a posterior increased soft tissue density with phleboliths.
Okay, so just 1 second. Let me recap for everybody. So what do you think, how will you describe the finding here?
So there's an ill-defined area involving the lateral cortex. It has a wide zone of transition. It's poorly defined, and I'm concerned that this represents an aggressive process. There isn't any associated involvement of the medullary cavity, and it's quite focal in nature.
Right. So what would you like to do to characterize this?
So I would recommend an MR.
Okay, so this MR, you can scroll through it. Let's see if it works. It's in a PowerPoint mode, but the images will come one after the others. And all of the audience, if you can just take your time, just scroll through it slowly and keep making up your mind what is happening. And if you want to describe it, there are 4 or 5 series which have been given to you.
Okay.
So on this series, can you describe your findings?
Yeah. So we got posteriorly. There's multiple.
What is the sequence?
So this is a fat suppressed sequence. It's a stir.
It's a stir sequence. Please continue.
So in the posterior compartment or in the calf aspect, there is an increased serpiginous structure which appears quite tortuous. It appears to also be in continuation with the vessels.
What's happening to the fibula vis-a-vis the lesion?
So the fibula, there's also mild edema, very mild edema of the fibula, and it appears to also have a local mass effect extrinsically, so an impression of an extrinsic compression on the fibula from these.
Please continue. There are more sequences for you to see. There will be axials also.
Okay. So once again on the axial, I can see these serpiginous.
Can you stop here? Can you stop here?
Yeah.
Now, where is tibia? Where is fibula? And what sequence this is?
So this is an axial stir sequence, and the fibula is here. I don't know if you can see my mouse, but it's...
Yeah, we can.
And the tibia is here. So this posterior serpiginous structure, which is predominantly within the gastrocnemius muscle, appears to circumscribe around the fibula posteriorly and is in close contact with the fibula and appears to extend within the cortical aspects laterally, which will be corresponding to the finding that we found on the X-ray.
Okay, just stop here, please. Anything comes to your mind? What is happening in this region?
The patient, the diagnosis. I think given that it's serpiginous, there were what I thought were phleboliths, and in continuation of the vessels, I think this may represent a vascular malformation.
Okay, please continue. Please continue. There are more sequences. What sequence is this? Can you stop here?
Yeah. So the marrow is quite bright on this sequence, and the muscle is of intermediate signal. So I think it's a T1 weighted sequence.
Correct. This is a T1. Please continue.
So
Stop here, please. Yeah. Can you describe your findings?
So using the muscle as a reference point, there's intermediate signal involving the fibula, and external to the fibula within the soft tissue, I can see a slightly high subtle area within the local muscle. And
Right. Please continue. So this one is with contrast.
okay, one in this sequence, I can see enhancement within the muscle on this side here, and the gastrocnemius muscle. There appears to be areas of increased enhancement, and once again, I can see bright enhancing signal within these areas, which will be more in keeping with a vascular malformation of the lower limb.
What do you mean vascular malformation? Which kind of vascular malformation?
Which kind of vascular malformation? I think it's a venous malformation.
Okay. How will you confirm this diagnosis?
So I think I'll have a look and see if I'll try and follow the vessels back and see if it connects to vessels or arteries. The patient will likely need further imaging, and
What kind of imaging?
So interventional radiology may have a role in this aspect. Doing a catheter angiogram may be helpful, and
okay, I'll take over, please. Right. Okay, well done. So the point is, this is an exam case, and the key thing here is that if you see there is an aggressive lesion here, and then we saw on MR that it had to be aggressive because whatever the lesion is, it was invading the bone. Key thing is these phleboliths. So this is what we call a intramuscular hemangioma. Of course, you are right. These days, the classification is different. And there is a concept of venous malformation, we know lymphatic. There's a bit of classification according to which component is dominant. Now, here, one take-home point for sequences in MR for the exam is that use the terminology of what we call fluid-sensitive sequence. So if you don't know it is a T2 or a PD, fat-saturated, if you are very sure it's a star, it's fine. Otherwise, if you use the terminology, it's a fluid-sensitive sequence, you cannot be wrong. So what is happening is that this lesion, as we saw, it is invading the bone, it is transspatial, it is intramuscular. And here, if you look carefully, there are fluid levels. And this is that phlebolith, this is that phlebolith. And key VIVA point is how will you confirm it? And interestingly, you will confirm it with a Doppler. So what we do is you just do a compressive study with Doppler, and it will just compress. Compressibility is what you are looking for. So, and on the plain film, if you do not pick up the phleboliths, then you will completely take it wrong and you will say that this is an aggressive lesion. Please remember that there is no role of, it's not an arteriovenous malformation. It's a venous malformation. Old name was intramuscular hemangioma. If you want to use that word, it's fine. So it will be connected to the veins and not the arteries. Right. So this is your second case now. and your last case. So this is a 24-year-old diarrhea and weight loss with hip and back pain. Yes, please.
Okay. So frontal radiograph of pelvis in a 24-year-old patient, male patient. So the first thing that catches my eye is in the left proximal femoral shaft, there is an eccentric lesion.
I am not interested here. Don't worry about it. Please continue.
Sure. So I know the patient has back pain and diarrhea, so I'll start off with looking at the spine. Can't see any abnormality within the spine. There's reduced joint space within the sacroiliac. The sacroiliac joints bilaterally are not well appreciated and they appear to be fused. Having a look at the lower lumbar spine for any evidence of ankylosing spondylitis, I can't see calcification of the ligaments. Having a look at the femoral heads bilaterally, I can't see any evidence of avascular necrosis. There's no evidence of enthesopathy in the pubic symphysis or the pubic rami bilaterally. So given that the patient has diarrhea and bilateral sacroiliitis, my concern would be that the patient may have an inflammatory bowel disease such as Crohn's disease.
Okay, so we did an MR for the patient. Can you scroll through, give me your findings, please?
So starting with this sequence, this is a T2 weighted sequence in coronal plane of the pelvis. So, focusing on the sacroiliac joints to begin with, I can see some areas of high signal involving both aspects of the sacroiliac joints bilaterally compared to the muscle. As seen on the radiograph, there's reduced joint space and complete narrowing of the sacroiliac joints. I'd also have a look at the rectum and anal region for any evidence of inflammatory bowel disease. I can't scroll anymore.
You cannot? Sure?
Yeah, now I can. Okay.
Okay.
Yeah.
So go to the next sequence, please.
So this is a fluid sensitive sequence in coronal plane. And again, I can see bilateral signal change within the sacroiliac joints. It appears to affect the left sacroiliac joint more than the right iliac joint, and it appears to affect both the sacral aspect and the iliac aspect of the joints. There's also a impression of some irregularity to the sacroiliac joint space. Having a look here also at the anal region, I can see this abnormal high signal here. And it appears to, as I extend, it looks like it's extending. So there's a high signal and it appears to extend at approximately 7 o'clock upwards.
There are more sequences also.
More sequences, okay, I'll carry on.
Yeah, there is an axial and you might be able to orient it more. You know, this is, consider it a long case for you, right?
Sure, okay.
And the marks will be according to your findings.
Okay, so at 7 o'clock position in the rectum, I can see this high signal tubular structure, which appears to extend from the anal region. It has a central low signal focus within this area. Looking higher up, trying to see if it involves the anal sphincter. And doesn't appear to involve the anal sphincter. And I'm just having a look at this low signal focus within it.
Okay, that's fine. Please continue. Anything else in the bones?
Yeah, so having a look at the inferior pubic rami, I can see high signal anteriorly involving the pectineus muscles, more so on the right than the left, which would be in keeping with enthesopathy. And there's also abnormal high signal in the involving the right inferior pubic rami. So
roll through rest of the pelvis, go up.
An element of osteitis. Okay, I can see this. So there's also abnormal signal and some edema surrounding the sigmoid colon, and there's an area of.
So what is your conclusion?
So my conclusion, given that this is involving the anal region and the sacroiliac joints, this is likely to be enteropathic arthropathy, and it's most likely to present Crohn's because ulcerative colitis typically spares the anal region. So this will be my unifying diagnosis, and given these findings, I would recommend referral to rheumatology and gastroenterology. The patient will need possibly an MR angiography to have a look at the terminal ileum and to assess for any active strictures.
Okay, excellent. I'll take over. So as I told you, consider it a long case. Now on this was the finding which was picked up. There was sacroiliitis bilaterally. And on this T1 weighted sequence, even here you can see this loop of bowel to be thick walled. And even on this coronal, you can see that there is a perianal fistula. Actually, this is a perianal fistula. It goes to 6 o'clock position. So the cutaneous opening was closer to 7. Otherwise, it was 6 o'clock. Now, this sequence, the T2 weighted sequence, is not a very sensitive sequence to pick up bone marrow edema, though because the finding was quite emphatic, we could see something happening. Now, for seronegative arthropathy, the key sequences are T1 and STIR. So once you know it, there is no harm in using this word STIR. Of course, you are not right and not wrong if you say it's fluid sensitive, but the point is that if you know it, for example, in head and neck, we know we always do a STIR sequence. Just call it a STIR sequence. So for seronegative arthropathy, we always use T1 and STIR. Now, you can see so many sites here. You know, enthesopathy, here, you know, these ischial tuberosities, and then this is that fistula, which is also on this coronal sequence. In the exam, they might not give you as many sequences as I have given you. They might just give you axial sequences, and time is an issue. So if I give you too many sequences, then it's not good for you actually. So even here, you can see this bowel to be inward. So if you see this is the sigmoid colon, of course, it's very difficult to pinpoint what it is. Actually, it was the small bowel. It was not in continuity with the sigmoid. So here, you can see it goes, and then at 7 o'clock, it communicates here, sorry, 6 o'clock. Right. Okay. Thank you very much, candidate 1. And now we go to candidate 2. Can you raise your hand, please?
Really?
Okay. Thank you. So I am going to stop this share, and I am going to show you Can you see it now?
Yep. So I've got
Just tell
right.
me what is happening here.
There's an impression of a lytic lesion with a peripheral area inferiorly of sclerosis. There's no aggressive periosteal reaction.
So if you see the AP view, do you think it is a lytic lesion or?
It's more of a kind of, I get the impression that there has been a lesion and that there's localization or something or going along that line.
MR of the same patient.
Fine. So there is an active lesion within the proximal tibia that is hypo-intense on T1, hyper-intense on STIR, and is central but within the epiphysis. It's got quite cauliflower, and on the cauliflower appearance, and there was an impression of arcs and swells. So I think this is a chondroid lesion, and depending on the age of the patient, I think they were older. So a chondroid myxoid fibroma is a differential, or?
So is there, the patient has got knee pain. Do you think this lesion is aggressive? There is malignant transformation?
It's got a narrow zone of transition, and there's a paucity of any surrounding bone marrow edema, and there's no soft tissue component.
Right. Okay, let me take over.
Yep.
You see, enchondroma versus malignant transformation of enchondroma to a chondrosarcoma is an important exam case. So please remember the basics that enchondromas, or these days they are referred to, chondroid lesions. They just call it chondroid lesions. So meaning that there is cartilage, chondroid cartilage. Has got the chondroid cartilage we are talking about is, this calcification or calcific matrix on a plain film. On an MR, it gives you this lobulated, appearance on fluid sensitive or T2 weighted or PD weighted sequences. It's quite classical. The calcification within it might appear low signal. The malignant transformation of an enchondroma or chondroid lesion, whatever you want to call it, on a plain film has got some characteristics, as in, it will become lucent, so there will be a lytic lesion and other parameters. So first of all, pain is again just like osteochondroma, then comparison with old films, then it will become lytic, so there will be end osteal scalloping, and the scalloping will be more than 2/3 thickness of the cortex might be involved, and similarly in a craniocaudal dimension, more than 2/3 of the height of the lesion will be involved. And if you've got an MR, then there might be some cartilaginous loss. So these are the parameters which we have covered before. But the idea here was just to show you a benign lesion, enchondroma, without any stigmata of malignant transformation. Now with that, let me show you another case. What do you think? Increasing right arm and shoulder pain.
So I would compare with previous to see if there was any other lesion or if this was new.
Right. So because of time factor, what do you think is happening? How will you describe this calcification?
Is it pigeon? I get the impression that this could be a bone infarct or...
Why do you say that? You used the word serpiginous. Where is it? Can you confirm? Can you convince yourself?
I would it's more of a sign on MR, I think.
Right. So your initial answer was that let's go back, and you say that I want to compare it, right?
Yep.
So we did not have X-ray to compare, but on PACS there was a chest X-ray, and on chest X-ray the right humerus is visible here. So the lesion was there, right?
Yeah,
so,
and stable in appearance.
Put it right and left. Anything comes to your mind?
Overall, broadly, it appears to be in the same distribution in length, but what I would be looking for is endosteal scalloping and increased lytic lesion, which there is increased lucency in the inferior aspect of the lesion. This, alongside pain, is concerning for malignant transformation, so would need to further evaluate with MRI.
Right. So the concept is that if there is malignant, it becomes differentiated. If it becomes malignant, it might eat up the calcification or the chondroid matrix. So there will be destruction and it might become more lytic or lucent. This particular case, I don't have good sequences. So just to make the point that this is the classical chondroid matrix we were talking about, and this is that lucency. If I give you axial here only, then you will see it very well. So here there is, one can raise the issue that there is malignant degeneration of chondrosarcoma, and chondroma. So please remember, malignant degeneration of osteochondroma, malignant degeneration of enchondroma, both of them are exam cases. For enchondroma, do not do a mistake, which many people do. Many people say that I will do a nuclear scan. And nuclear scan, the problem is that nuclear scan is absolutely non-specific. Enchondromas, I think about 30 to 35% of them, they might show uptake. So that is not a criteria. Don't use a nuclear scan. Okay. This is 23-year-old. What do you think is happening in this knee joint?
There's a large joint effusion.
And there is no history of trauma. What comes to your mind?
A hemarthrosis.
What will you do next?
An MRI.
So this is the MR. What sequences are these ones? What do you think?
I've got these are at the top. I've got PD FATSAT and or T2 sagittals, and the first on the second row is T1, and then axial T2 FATSAT. So yeah,
Okay.
and
so
then
if you look carefully inside, do you see this low signal?
yes, I've got diffuse low signal, and then kind of erosions with that, which would be I would want to look at a T2 star to see if there was blooming.
These are T2 stars.
Fine, so there's blooming artifact within that confirms that this is either, but it looks like lobulated, so it could be PVNS rather than hemarthropathy.
Here you are. So this is classical PVNS. You see the patient has presented with effusion without any reason. And then you have seen this hemosiderin. A T2 star is the king sequence here to pick up this hemosiderin, which will be low signal. And please remember that there can be, in your Chapman, there is a differential diagnosis of subarticular lucent bone lesions, very important exam case, and in which PVNS is up there, because you can see what is happening here. So the point is that at times in PVNS, in exam cases, there will be lucent lesions on both sides of the joint. So this is PVNS. Okay, let me show you VIVA type of a case. Now, in the right hip, 73 male. Over to you.
Okay, so I've got an AP pelvis of a 73-year-old male patient with right hip pain. The hip joint is normally in normal alignment. There are no focal lesions of the upper femora. Looking closely at the acetabulum, is intact, as are the pubic rami. There's an impression of, I think it's projectional, but there is an impression of lucency over the left pubic rami, but I think that's just projectional because it's going a little bit convoluted. But there is definite asymmetry overlying the sacral alar, and I'm concerned that there's a lytic lesion.
Okay, don't worry about it. Come anteriorly, anything happening at the level of, let's say, the ischial tuberosity, look at the soft tissues also.
There's asymmetry in the soft tissues of the medial compartment of the thigh.
Excellent.
Just looking at the adjacent cortex, there's possible increase. So actually what I was perceiving as lucency on the left could be sclerosis on the right. I'm seeing thickening of the iliopectineal.
Can you please point out if your mouse function is working? Yeah, excellent. So you've picked up something, and with that, where is the soft tissue? The asymmetry, okay, very good. What will you do next?
I would need to evaluate, preferably with MR, if resources would allow.
So over to you, please.
So T1 axials of the pelvis. I'll just try and get down to the... So there's a hyper-intense T1 signal in the left, in the right, so hypo-intense signal in the right acetabulum. Where replacing with a large kind of lobulated soft tissue, replacing where the acetabulum should be, and involving the muscles of the perineum and obturator.
Because of time factor, please keep continuing. You have got more sequences.
Okay. So now this is fluid sensitive, fat suppressed, and the lesion that I was describing is of a heterogeneous density with hyperintense septa and marrow edema in the surrounding bone of the upper femora, but it's completely replacing it. So I've got a grossly destructive lesion in the right acetabulum that's extending into the soft tissues of the adductor compartment of the right medial thigh.
Right, and next sequence, please.
So this will be presumably T1 post-contrast. No.
Still a T1, right?
Yeah, it's just T1. So it's T1 coronal.
Please continue to the next series.
Okay, the lesion's iso-intense to muscle on T1, and this is a post-contrast T1, which demonstrates homogeneous.
This is a
fat-saturated contrast-enhanced study.
So fat-saturated pre-contrast.
Pre-contrast. Okay.
Yeah, pre-contrast. So, in MSK imaging, whenever you want to give contrast, you have to do a pre-contrast fat-saturated so that you can compare it, right?
Yeah. So this will be the post-contrast, and in comparison, there is heterogeneous and predominantly peripheral with some septational enhancement.
Okay. What is your conclusion?
There is a large soft tissue mass lesion that is causing gross destruction of the right acetabulum and involves the muscular compartments. It is seemingly centered on the right acetabulum initium. Differentials for a patient of 73 would be a large metastatic deposit. Another differential would be a primary bone malignancy, such as osteosarcoma. Those would be my two main differentials.
Okay. I'll take over, please. Thank you. Now, as I've told you in the beginning, these are favorite for the exam, where they will show you a film in which the finding will be subtle, just like this case. Subtle finding, but a definite finding, and with that is this. Now, there is on a T1 weighted sequence, there is destruction, and with that there is a huge soft tissue lesion, and it is, of course, the inferior ramus, the ischial tuberosity, the acetabulum, everything is involved. And then the same thing. I've given you too many sequences. Usually they will just give you 2 or 3 sequences, and maybe just axial, or so you have to develop your eyes. So this was a point that classically, whenever you do a contrast, you have to do fat saturated, and for that the pre might be given, and this is a post. So there is a lot of necrosis, etc. So this is a soft tissue sarcoma, which is invading the bone secondarily. Please remember, osteosarcoma is a young age tumor, right? That is a young age tumor. Right. Because of time factor, I think I will go to the next candidate, right?
Thank you.
Thank you. So next candidate 3, are you with us? Have you, can you move your mouse? Have you got the control as a trial?
I don't think I'm changing it. I'll click the request button.
Now?
Yeah.
Okay. So just I'll take over. Okay. Over to you. Patient, the history is that this is 63-year-old female, pain in the upper back.
Okay, so this is a frontal radiograph. Looks like probably the AP part of a thoracic spine radiograph rather than chest X-ray. Given that there is a history of pain in the back, I'm just looking at the spine to see if I can see any obvious bony destruction or other abnormalities like that. I just mentioned that there appears to be quite a large retrocardiac opacity. I don't know if that's relevant in this case.
It is relevant. It is relevant.
Well, then I should discuss it. There's the appearance of a retrocardiac opacity projected over the lower thoracic spine, which appears to have a level within it, possibly an air fluid level. It's a rounded opacity, and I can't see the right paraspinal line very well. It might be disrupting the right paraspinal line, which would place this in the posterior mediastinum.
Right or left?
Well, left and right, really.
Okay. Can you point it out to me, what you are saying?
So I'm looking, there's round here, and I think it also comes around into this sort of area. And then there's also this edge here.
Okay, very good. Spine, anything in the spine?
So I'm looking for any vertebral collapse or any absent pedicles. I can't see the left pedicle of, I think that's T10.
Point it out to me.
So here, there should be a pedicle.
Excuse me, I cannot see the mouse. There is a,
Oh, oops, sorry. Can you see my mouse?
no. Oh, now we can. Okay.
Okay.
Go
So,
back, please. Go. Yeah, now.
this is the area I'm looking at.
Yes.
So here's a pedicle, here's a pedicle, here's no pedicle.
Excellent. Anything else?
It's a little bit difficult in terms of the penetration, but I just wonder whether there's some lucency here, and then the inferior border of this, where there should be a rib, and I can't see that rib very clearly at all. I think the appearances are of a destructive lesion centered around the left paraspinal area in the lower thoracic spine. It also appears to have rib destruction associated with it. I think the patient should have, so we've got a...
I have gone to the lateral. Where is it placed on the lateral? The opacity, the mass, whatever.
So again, it's posteriorly placed.
Excellent. What will you like to do next?
So I think the patient needs cross-sectional imaging. A CT would be reasonable, but
I have given you an MR instead of CT. So over to you. You can scroll it.
Okay, I'm just going to scroll.
On this sequence, you will describe your findings to me.
Yeah. So this is a T1 weighted sagittal. There's an abnormality which is essentially ISO intense on T1, and it's found, as we identified on the X-rays, in the posterior mediastinum. It's causing, if anything, splaying of the adjacent ribs rather than necessarily destruction, and it can be traced backwards into the spine. So it's passing. So I think it's either passing through a neural foramen or it's potentially actually arising from this. This is the location
please
of the pedicle.
Continue. Go to the next series, please.
Okay, I'll just scroll through. Yeah, I think that was actually emanating from the pedicle. And what we've got here, this is a T2 weighted sagittal sequence. I'm focusing on that same lesion. The bulk of the lesion is T2 hyperintense with a thick lower intensity wall with some heterogeneity within it. And then again, it seems to emanate specifically from this, the pedicle of the adjacent vertebra.
Right. So you have got more series, just go through them.
Yeah. That's an axial T2 weighted sequence, which shows that same lesion. I can add to the previous finding that there appears to be a fluid level within the lesion, implying some differential contents. I can see the focal rib destruction here. The normal dark sclerotic cortical border is lost.
Yeah, please continue. There are more.
Okay.
So what series is this one? Just stop it, please. Name the series. What sequence?
So the fluid is hyper intense, but not as much as the T2. I wonder whether this is a PD.
Look at the CSF.
And the CSF is still relatively bright. It's not as low signal as you'd expect in a T1. Perhaps it's and the fat is mostly suppressed, so it's probably a stir.
On a stir sequence, the CSF will be very bright.
Yeah.
Okay, next sequence, please. This is with
So
contrast.
this is a post-contrast, and we can see vascular enhancement in various places. And the previous one, therefore, was probably a T1 pre.
Yeah. So how do you explain that high signal within it?
So then what that says is that the internal contents are not just pure fluid. They must be either proteinaceous fluid or mucinous fluid, or potentially, the other causes of T1 intrinsic high signal, so melanin, cholesterol, etc.
Okay, what is your conclusion?
So there's a large paraspinal mass which has a thick peripherally enhancing wall and is causing bony destruction, and then internally contains non-enhancing fluid that is high on T1 weighted imaging. I think, and this is in an elderly or older patient who's presented with pain. I think the lesion looks aggressive, and I think that I would consider diagnoses such as malignancy, potentially metastatic from a primary that causes high T1 signal, such as a melanoma or a potentially a mucinous adenocarcinoma, and this could be.
Okay, thank you. I'll take over because of the time factor. Now,
I suppose the rim enhancement, could also imply abscess formation as a differential.
Okay. So let's go back, and the point is that you picked up very well. Pedicle is missing. Now, then you look at this. Now, this is rib. This is rib. Look at this distance. This it has increased. You picked it up actually. That there is a bit of scalloping. Whatever is happening, it is a long-standing process. It is not causing bony destruction. One point. Second point is that if I give you this film on a chest X-ray, and you remember posterior mediastinal masses, and up there is neurogenic tumors. And then within neurogenic tumors there can be so many. Neurogenic tumors, please remember, can have cystic components. Just like in the brain, you can have a cystic acoustic schwannoma. Remember that. So they can have, radiologically speaking, many types of appearances. So these things tell you, just this pedicle, you cannot comment. But once you see this is long-standing. And then here, you picked up very well that it is going into the neural foramen, and on the axial also, that was confirmed. So another point here will be that on T1 pre-contrast fat saturated sequence, the physics is slightly different and everything becomes slightly higher signal than normal. And at times you will make a fool out of yourself, particularly in the spine, where it will appear very high signal. And actually that is normal. It's normal physics. So develop your eyes on a T1 fat saturated pre-contrast. And this was given just so that you can compare it. Of course, in the real world, on a DICOM viewer, this will be, you can, the next sequence will be with it, so you will not be handicapped. But this was high signal, means there is the simplest thing is its hemorrhagic component. Of course, it can be proteinaceous, but it's hemorrhagic component. Just like, think like an endometrioma, and now you can see that the periphery is enhancing. So point to remember is that neurogenic tumors can have cystic component. So this was a neurogenic tumor. But again, the emphasis which if you see all of the cases which I have shown you, subtle finding, and then characterization of MR. So that is what exam cases are about. Okay, I will again go into the spot diagnosis, please. Can you see my screen?
Yeah. So I can see that there's a quite large lytic lesion in the metaphysis of a skeletally immature patient's tibia. It seems to have a fracture, or at least some cortical irregularity at the medial aspect. I think this, I mean, it's not projecting very well for me, but I think it could be a simple bone cyst with a pathological fracture for it.
Right, and I can appreciate that it's not projecting very well. The resolution is not very good. What do you call this thing?
So in that case, that would be a fallen fragment.
Right. Now, simple bone cyst. What else can it be?
So there, I mean, then there's other differentials of lucent bone lesions. It could be not simple. There could be an aneurysmal bone cyst, but there's no real expansion. Something I'd always want to exclude in a pediatric patient with a metaphyseal lucency is a Brody's abscess. It doesn't have a hugely sclerotic border, but in that case, the more sclerotic part in the center could represent a sequestrum. I'd also be thinking of an eosinophilic granuloma. I think that there's a possibility. I think the lower inferior border of the lesion on the AP projection, certainly for me, doesn't look very distinct.
No, it is. So you are a bit handicapped because of the resolution, so don't worry about it. I've got an MR of this patient. What do you think?
Okay, so on fluid-sensitive MRI sequences, sagittal and axial, what we can see is the lesion has multiple internal locules with fluid levels. I think this is typical for an aneurysmal bone cyst.
Excellent. Okay, let's go back to the basics. Now, your differential was fine, but the point is that how do you differentiate between a classical textbook aneurysmal bone cyst which has expanded like anything? Don't think that all aneurysmal bone cysts, when you image them, will be as aneurysmal. So, one of the key things to differentiate between an ABC and simple bone cyst is that is it central in the medullary cavity versus eccentric. So classical location of aneurysmal bone cyst is, you remember that diagram in Chapman where simple bone cyst is central and aneurysmal bone cyst is eccentric, and this is slightly eccentric. And classical location of aneurysmal bone cyst is metaphyseal, and simple bone cyst classical location is metadiaphyseal, here central. And then there is a concept of migration of cyst where it migrates towards the diaphysis as the child grows. So that also goes in favor of, but in the exam, nobody will mind if you say both of these things. But having said that, retrospectively speaking, these points are valid, as I pointed out. Please remember, fallen fragment sign is not a pathognomic sign for simple bone cyst, and it can be seen in other stigmata. And then fluid levels. If you see more than 75% fluid levels, you are quite confident that it is an aneurysmal bone cyst. Yes, please.
This is a lateral radiograph of the right calcaneum of a skeletally mature patient. There is a well-defined lucent lesion in the mid to anterior part of the calcaneum, which is, as I mentioned, predominantly lucent, but there are some speckles of calcification within it. They make me consider that that might be some matrix calcification, in which case I think this lesion is consistent with a enchondroma. A differential would be a calcaneal lipoma, intraosseous lipoma, which if chronic could potentially have a bit of calcification within it. I think the lesion has benign features, and there's no periosteal reaction or soft tissue.
What will you do next?
I'd be interpreting the radiograph in the light of why it was taken. If this is an incidental finding, I don't think it requires any further action. But in any case, I'd be comparing to any previous imaging to see if there's serial change in the lesion.
So there is no previous X-ray.
Okay. I think that radiographically this lesion is benign, and I don't see any evidence of a fracture or any other complication associated with it. If there was any clinical concern about the nature of the lesion, a focused MRI scan would be a reasonable course of action.
MR?
So what we've got is sagittally oriented, fluid sensitive, I think a stir in the middle, and a fat sensitive sequence. Looks like a T1 weighted or sequence. The lesion is inherently high signal on the fat sensitive sequence, and saturates out on the stir, so I think this is a lipoma.
Right. Okay, let's go back to the basics. You picked up a lesion there, and your differential was lipoma versus enchondroma. By the way, whatever you were seeing this calcification, there is a bit of central, maybe here calcification, but a bit of trabeculae are also projecting. It's not classical chondroid matrix. This is also not a classical site of enchondroma. You know, calcaneal lytic lesion is a very important exam case. It has come in the exam many a times, and there are specific things which you have to remember. And one of them is simple bone cyst. You know, it all depends on the age group. So in here you are a bit handicapped, but you feel that this is not a child. So chondroblastoma can occur there, and in a slightly advanced age group, not advanced, middle age, it can be a giant cell tumor. It can be a lipoma, as you have pointed out. It can be what we call, hemophilic pseudotumor, calcaneal, that is there. Known site, and it has come in the exam quite a few times. Brown tumor of hyperpara, this is another one. So there is quite a favorite location for a specific differential, as I have told you. And some of the things might not be very specific. So nobody in this era is stopping you to ask for an MR. Don't be shy of asking an MR because you are unable to characterize this. In the real world, you know, there are some lesions. So I'm coming out of this case and giving you the general concept that what we call don't touch me lesions. When you are in a black and white world, in a plain film, for example, there is a fibrous dysplasia, just call it a fibrous dysplasia, and there will be no role of further imaging. A non-ossifying fibromas, call it a non-ossifying fibroma, or a fibrous cortical defect, or a simple bone cyst if you are, but here you are not very sure. So ask for an MR. Yes, please. This might be the last case of the day. You know, we have already gone beyond about 20 minutes. So this will be the last case for you.
So I'm presented with AP and lateral radiographs of the right humerus of a 62-year-old female. The bone looks broadly quite normal, but there's an obvious abnormality of the soft tissues of the anterior compartment of the arm, where there is some fluffy, slightly amorphous calcification quite irregularly distributed, which implies that I think there's a soft tissue lump there within the arm. I'm trying to see whether this is scalloping the adjacent humeral cortex or indeed potentially arising from the bone. I can't see any convincing evidence that it is. But nevertheless, there's clearly a quite large soft tissue lesion, probably within the muscle layers. I'm told that it's quite long-standing. If it's been previously investigated, I think it would be a good first step to review any prior images to see whether it's got larger. Otherwise, further investigation is necessary because the calcification might only represent part of the lesion.
And what do you think can it be? Do you see this? What do you think? This density here.
So it looks like, if we take it that the entirety of the lesion spans from this curvilinear area of swelling all the way around to this sort of area, that some of it is projecting as soft tissue density, some of it is calcified, but some of it might be fat density.
Right. So what are you going to do next?
So then I think, especially if this is growing or painful, we've got to be concerned for potentially a liposarcoma. I think an MRI would be appropriate.
So T1?
Yeah.
This, and then pre-contrast and post-contrast sequences are here.
Okay, so just reviewing those sequences, there's an ovoid lesion located primarily posteromedial to the humerus. This contains quite heterogeneous tissue of various signals. A large part of it is hyperintense on the T1 and saturates out on the fat-saturated sequences consistent with macroscopic fat. But there's also a T1 iso intense soft tissue component that appears to be enhancing after the administration of contrast, and some low signal foci which probably represent the calcification. The overall appearances are suspicious for a soft tissue neoplasm, and a liposarcoma has to be considered a possibility. Therefore, I think the patient should be discussed at the regional sarcoma MDT and planned for a biopsy made with their input to ensure a safe tract.
Right. Okay. So you see, liposarcoma is an exam case, and both type, the lesions which are black and white, like this case, this is a definite liposarcoma. And second are lesions which are, in the gray category. And how will you deal? Both have come in the exam. So this is a slam dunk, absolute, imaging-wise, this is a liposarcoma. It gives you low density, then calcification here. And so it was long-standing, means initially it must be a lipoma, and then it has converted into a liposarcoma. And classical, this is the fat component, and then this is, enhancing component on. So you did well where you referred it to the sarcoma unit, and they should do the biopsy. You should not do the biopsy, everything. So that is all. Right. So what we will do is that tomorrow we will continue this format. My idea is to crack on with all kinds of MRs which have come in the exam from MSK world. I have not intentionally shown you knee MR, which is trauma. I have not shown you shoulder MR, which is supraspinatus and all those things, Hill-Sachs, Bancart lesion, which will be covered tomorrow by Dr. Sajid Bhatt. So otherwise, I'll show you all cases which have come in the exam as far as MR. So thank you very much, and we will meet tomorrow at 1800 hours, and then we have got spine on